or the storage subscore, it looks like tadalafil compared to placebo has a dramatic effect on the IPSS scoring. This was looking at an integrated analysis that was published in Journal of Urology about 10 years ago. And it showed that really looking at across 4 different large cohorts of men, that it really is an effective treatment for LUTS. So that's fantastic news, because if you look at a PDE5 inhibitor and you think about what we're all very familiar with PDE5 inhibitors, we know that, like all drugs, there are side effects and there's positive effects. But with PDE5 inhibitors, certainly there's no negative effect on erectile function. Whereas with many of the other treatments for BPH LUTS, it really does cause sexual dysfunction, ejaculatory dysfunction, and a whole host of other conditions that really, for many men, discourage their use. There was always a concern about cardiovascular risk. And what does a PDE5 inhibitor, or even an alpha blocker for that matter, do to the cardiovascular system? And this was a study that we published, again, about 9 years ago now, that really showed that there is no concern about cardiovascular risks. Interesting, and I think Dr. Pandya and I were talking just previously about how widespread the recent Kloner article that looked at the PDE5 effect on cardiovascular health was recognized within the Indian subcontinent. That was a fantastic study by Kloner that came out now about 9 months ago and showed that PDE5 inhibitors, in fact, are protective for cardiovascular disease, and there is a dose-response relationship, so that the men that took more PDE5 inhibitors gained more protection against heart attack and stroke compared to an equally matched cohort of men who were on placebo. So really, really powerful data from a cardiovascular standpoint with respect to PDE5 inhibitors. The integrated analysis speaks to the cardiovascular safety. We did look at a group of men specifically with tadalafil. This is 1,500 patients from an integrated analysis to really understand what they're seeing in terms of tadalafil 5 milligrams. And I think I mentioned earlier that there seems to be a cutoff. 2.5 and placebo look very similar. 5 milligrams is basically equivalent in terms of improvement in lower urinary tract symptoms to 10 milligrams or 20 milligrams. This is a 5 milligram compared to placebo, and what it shows is a marked improvement in the percentage of patients with a response in terms of their lower urinary tract symptoms. So, as Dr. Pandya said, this is a really exciting time. We're now in a situation as urologists where we have a large group of men, and specifically those men who are fairly young, men who are 60 or less, who are active at work and want to be active in the bedroom, are active in many aspects of their life, but are often troubled by lower urinary tract symptoms. And in my patient population over the last, more than 15 years now, I've been co-administering alfucicin for their BPH symptoms, because men don't really like the idea of many of the other alpha blockers that cause sexual dysfunction and ejaculatory dysfunction, whether it's silidocin or tamsulosin or some of the non-selective alpha blockers. So my go-to alpha blocker for a long time has been alfucicin. In Canada, it's called Zatrel. And I've been combining that with 5 milligrams of Cialis for the last 15 years and have a huge experience, literally thousands of patients that I've treated over that time period. Unfortunately, in Canada, we don't have a fixed dose combination as you do now in India. So I'm quite jealous, but I can tell you that I have a huge experience with this co-administration in this patient population. And I can tell you that it really is a huge advance, especially for the younger patient, the one that wants to retain their sexual activity. So let's go through some of the data now. Over the next little while, I'll share with you the idea of a fixed dose combination, the patient population, risks and benefits, and then we'll have a chance to ask questions and talk amongst ourselves about the practical aspects of really treating this really large and really affected patient population. So if we look at men under 60, more than half, when you ask them, actually have some significant issue with respect to voiding dysfunction. And that's data from India itself. And what is a younger man? Well, again, that's really poorly defined. There's no clear cutoff. And I think that various parts of the world would probably look at that question differently. I think in Canada, we would consider younger people 60 or less, and it looks like in India, it's very similar. If you look at some data, whether it's from the Indian Ministry of Social Justice or the United Nations, 60 seems to make sense in many parts of the world. If we look at why, well, there's a couple of things you can look at. Most men under 60 are still actively employed. They're still fairly active physically. And this survey that was done about 15 years ago now, or 14 years ago now, looked at the cutoff between men who are 50 to 60, 60 and above. And what they found was there's a clear cut in terms of under age 60, that group of men are more likely to want to be sexually active and have more sexual desire. So the fact is that in an older man, quite honestly, in my patient population, man in his late 70s, 80s, or beyond, sexual function is not nearly as important. And loss of ejaculatory function doesn't have a huge impact on their quality of life. Whereas when I give an alpha blocker that's non-selective or is not alfusigin to a man in his 40s, 50s, and sometimes even to his 60s, loss of ejaculation is a major impact on decreased sexual satisfaction. So it's something to consider. The steep decline that we see in sexual interest and sexual activity really seems in many populations, and certainly from this data in India, to occur around age 60. So I think when you're thinking of your patients under age 60 who come in complaining of BPH-LUT symptoms, and you're thinking about how to best treat them, the fixed dose combination makes a lot of sense, particularly if they want some enhancement of their erectile function, or they don't want to lose their current sexual capacity. And that's the group of men that have an active life, an active work environment. They want to be sexually active, and they want to have an improvement in their lower urinary tract symptoms. You know, the whole idea that in this patient population, when they see you in the office next week or whatever, and it's a man under 60, he comes in, he says, you know, I'm starting to have some problems in the bedroom. I think I'm also having problems in the urinary situation. It takes me longer to go. I have some dribbling after I go. I don't believe I'm emptying my bladder completely. We have a number of choices, and those patients have choices. And certainly for many men who are just starting to complain, I think most of us would agree that medical therapy would be the first approach, that going ahead and offer them surgical intervention, whether it's minimally invasive things like a UroLift or Rezum or a TURP, are probably relegated to those who fail medical management. In medical management, you can look at a 5-alpha reductase inhibitor, but if the guy doesn't have a big prostate and he wants treatment right away, he doesn't want to wait 6 months, and we know from data now over the last 3 decades that a 5-alpha reductase inhibitor for a guy with a relatively small prostate, and even those with bigger prostates, doesn't often cause a significant improvement in symptoms. So we're relegated to alpha blockers for most of the time, for most of our patients, unless you want to go down the antimuscarinic, anticholinergic, or beta-3 agonist pathway. But that doesn't improve the urinary function, that just improves their symptoms. So we're left with an alpha blocker, and then an alpha blocker can cause significant side effects. The beauty of the fixed dose combination is it treats the patient and it really minimizes side effects. And what that results in, from my perspective, is these important points: retention of their sexual function, in fact, enhancement of their sexual capacity. It improves their urinary function, and basically you end up with patients who are happy, and that means they don't bother any of us. If we look at the proportion of patients who in fact do have significant lower urinary tract symptoms, this is again Indian data, a little bit dated now, but still probably very appropriate. You can see that at age 50 to 60, roughly a third or more of the men actually have significant issues with respect to lower urinary tract symptoms. And of course, men in their 40s and 50s, and even men in their 60s, sexual function is very important to many of them. And I would argue that really, even though it is a little bit dated, that I think the proportions of men are, if anything, are higher now with lower urinary tract symptoms who want to retain their sexual function. I don't think it's changed very much, and I think that group under age 40 is still quite significant. In my clinical practice, on a routine basis, I see men in their 30s who are starting to complain of lower urinary tract symptoms, and I do give them the combination of 5 milligrams daily dose of tadalafil in combination with alfusigin, and I can tell you the vast majority are delighted. So we think that the prevalence is still increasing. We think that the idea that it impacts quality of life, workplace efficiency and productivity is really significant for many of these men under age 60 who want to improve their lower urinary tract symptoms but avoid the sexual dysfunction that can come with some of the other options. We know from many studies across the last 3 decades that men who have lower urinary tract symptoms, in addition to those men who have erectile dysfunction or sexual dysfunction, it can have a dramatic impact on their quality of life in a couple of different areas. It affects their interpersonal relationships at work, at home. It also causes men to worry about the problem of voiding, not being able to be at the workplace as often, having to think about where's the bathroom, did I empty completely, am I going to get an infection, can I travel? Maybe these men don't even want to do work-related travel because they have the issue with lower urinary tract symptoms. So in many ways, a simple tablet that co-administers both of these agents seems to be ideal from my perspective. And so these are some of the issues that can happen with men who have quite significant lower urinary tract symptoms and maybe have sexual dysfunction in addition to it. You know, the data on the comorbid condition, men who have lower urinary tract symptoms, the likelihood they also have erectile dysfunction is incredibly high. And we think that the pathway is a physiologic one that probably related to nitric oxide release, that you get an effect on the lower urinary tract, but also an effect on erectile mechanisms. And so it manifests with potentially anxiety, depression, isolation. So, you know, we're not psychologists, we're urologists, we're very pragmatic. We want to treat men effectively in a comprehensive way. And when they have multiple complaints that we can treat with a single tablet because it contains 2 different pharmacological agents, I think that's a real win. So the fact that men have problems in the bedroom in addition to the boardroom, and you see here on this slide, it talks about the fact that men with significant erectile dysfunction are more often to also have lower urinary tract symptoms. There were some terrific studies that looked at the co-administration of these drugs, and we're going to share that with you now, just so that you understand that what I'm saying is based on data, that there's good evidence that it's effective, that it's safe, and that it has a long, durable effect. So when all of us see our patients, you know, we want to figure out what's the best way to treat them. And I think that whether it's in India, Canada, the US, or most of the civilized world, that men would typically get alpha blockers as their first treatment. And typically it's monotherapy for many of those men. So this was a study that looked at men over age 50 with mild to moderate lower urinary tract symptoms. They had an initial IPSS of just over 15 points and a Qmax that was impaired at 12 cc's per second. They got a 3-month trial of alfusis, tamsulosin, and silodosin. I think those were well selected because they're very popular and commonly used. You can see that there was efficacy with an improvement in IPSS at 3 months and a modest improvement in Qmax, about 3 cc's per second. And in fact, some of the studies now that we've seen with tadalafil show similar data in terms of IPSS number improvement, but this is a pure alpha blocker study. And what they showed was, interestingly, that whether you think that's not enough or it is a good response, many of these men will come back and tell you, yeah, doc, I feel better, I'm improved. I'm not terrific, but I do feel better. But they certainly do want to have something more. And so the question would be, well, what would happen if you combine some of these other alpha blockers with a PDE5 inhibitor? Well, we know that tamsulosin and silodosin have significant problems with ejaculatory dysfunction, and that by itself can cause significant quality of life issues. Looking at surgery, we talked about it before, even minimally invasive surgery certainly will affect ejaculatory function. It's expensive, there's recovery, there's post-op issues. And so particularly in those young, active guys, the idea of avoiding surgery early on makes a lot of sense. When we look at our choices, certainly lifestyle modification makes a lot of sense. So someone who's really perhaps abusing caffeinated beverages, fluid overload, whether it's not physiologic and it's situational, stress related, that's something to address, and I think all of us would. But again, the first line therapy, apart from lifestyle modification, would be the use of these alpha blockers that I talked about, and that I'll share you the data that all three are roughly equivalent in terms of efficacy. The difference is their side effect profile. 5-alpha reductase inhibitors, where they use dutasteride, finasteride, is going to have some side effects in terms of sexual side effects, lower ejaculatory volume, and an incidence of de novo erectile dysfunction as well. The PDE5 inhibitors we talked about before, and then surgery, of course, has all of the issues with it. So that study that I talked about earlier really does show equal efficacious improvement in lower urinary tract symptoms. But with silodosin, more than 1 in 4 men are going to have either anejaculation or retrograde ejaculation. Depending on your patient population and the dose of tamsulosin, you're going to get some weakness, fatigue, but abnormal ejaculation in certainly 1 in 10 men. And that's not the case with alfucisin. Although the efficacy is the same, the side effect profile is better. Well, what about PDE5 inhibitors? Why tadalafil? Well, the idea, of course, is tadalafil has a half-life of 17.5 hours. And if you take it once a day on a chronic basis, it builds up to a concentration that's equivalent to roughly 8 milligram equivalent. And that results in lower urinary tract symptom improvement, but constant exposure. If you take a once-a-day Avanafil or sildenafil, unfortunately, their half-life would mean that the drug wears off before you take your next tablet. And so you'd have exposure to all the side effects from a PDE5 inhibitor at a relatively higher dose without the efficacy long-term over the course of that whole day. So there's no question that tadalafil and its half-life and its efficacy and the data set that I described briefly makes more sense than any of the other PDE5 inhibitors. And this slide just really reflects what we're talking about when we're looking at an alpha blocker with alfucisin and a PDE5 inhibitor with tadalafil in terms of improvements in BPH LUTS, the ED impact, the ejaculatory impact, and the fact that once-a-day prescription is possible. So it really is, in many ways, the ideal combination for the issue that we're talking about. That younger man who has LUTS wants to remain sexually active, wants to retain his erectile function, or even in the man who has some degree of erectile dysfunction and wants enhancement. And the mechanism that we think happens through alpha blockers, as you all know, is it's a uroselective inhibition of the adrenergic receptors at the smooth muscle at the prostatic area and also at the bladder neck. And so that causes a decrease in resistance to flow, increased flow rates, and reduction in symptomatology for many men. The tadalafil pathway, of course, is it inhibits the metabolism of cyclic GMP, and as a result, it makes the nitric oxide that's released more effective in causing smooth muscle relaxation. Some of the other hypothesized pathways include perhaps through nitric oxide directly, downregulating Rho kinase, through autonomic nerve activity, and modulating some other pathways. It's not absolutely known, the exact pathway, but we believe it is typically mediated through smooth muscle relaxation. So when we're looking at all of this, you know, it's really interesting to see that there have been some very well done studies looking at this combination of alfucisin and tadalafil versus monotherapy with alfucisin. And this was a trial that was done in India, where you can see the inclusion-exclusion criteria here. And they looked at 3 different groups of patients. Alfucisin with 2.5 milligrams of tadalafil, which I would have told the company probably was not the right dose. Alfucisin with 5 milligrams, which is the ideal dose of tadalafil and alfucisin in combination. And alfucisin 10 milligrams as monotherapy. So as urologists, you know, as opposed to family doctors or primary care physicians, we really like to make clinical decisions based on data. And we get data from good studies. And this is a good study because it looks at exactly the combinations and looks at our patient population. And what you can see here is compared to baseline at week 4, 8, and 12, when we looked at the fixed dose combination compared to the alpha blocker alone, you see an improvement in terms of at all time points over monotherapy. So it looks like the combination is meaningfully and statistically significantly better, which is great news for us and for our patients. Across the board here, you see a difference. So that's great news. If we look at Qmax, you can see that there actually is also an improvement in Qmax from baseline, but also the fixed dose combination compared to the monotherapy alone. So many of my patients on alpha blockers will come back and say, honestly, doctor, thank you very much. I like the Zatrol. It helps me. It works well for me. I'm better. And then when I ask them, are you completely satisfied? They say, well, if you could make it better, that would be even better. And I think what we're looking at with this fixed dose combination is your ability in India to make it better easily with a single tablet. It will improve erectile function, improve sexual satisfaction, but also it'll improve the lower urinary tract parameters that we look at in terms of IPSS scores, flow rates, which is really what the patients are interested in seeing. So we saw that all of the side effects from the trial were mild in severity. There were no serious adverse events, and you can see them listed here just as you'd expect, really very low in frequency and intensity across all of these different commonly experienced side effects with alpha blockers or PDE5 inhibitors. Now, all of us who are here today are urologists, and we have huge experience with these two classes of drugs, so none of this would be a surprise to any of us. The good news, and again, not surprising based on all the studies, is that there was really no evidence of any worry with respect to hemodynamic parameters. Another study looked at a slightly different population, men over 50 who have an IPS score of 8 or more, and they looked at it again with combination therapy, alfuzosin, and tadalafil. And when we looked at that, it's the same thing. Both of these drugs work as monotherapy, but when you combine them, it really is the best combination. Best combination in terms of all of the parameters that we're interested in. What about those patients who had sort of a partial response to the alpha blocker? That patient that I typically see, the guy that comes in, he's better, but he's still not happy. Well, what happens when we give them the fixed dose combination? And you can see the results here are dramatically better. When you look at this information, it shows you that across the board from the baseline onset of study until the end of the study, there's a dramatic improvement in the combination trial. So it tells me that even among your patients who are currently satisfied with alpha blockers, you may want to actually introduce the idea that you now have something better. You could offer this fixed dose combination in which they get a PDE5 inhibitor and their alpha blocker, and they probably will be even better than they currently are. This is just a study that reassures you that even if they were using a higher dose of tadalafil, the 20 milligrams of tadalafil compared to the 5, there really is no sign of any hemodynamic concerns. So not a concern, and I think the concern about PDE5 inhibitors and alpha blockers is now historical more than anything else. So the concept is exciting to me. I've been using it, of course, for many years, but in India, you have a huge advantage now where there's a single tablet the person can take. And we know that way they get it relatively inexpensively, and it's easily for them to take it on a daily basis where they take the pill constantly, and it's the right combination. We know that this really is the ideal way and the perfect marriage of turbocharging that lower urinary tract and erectile function, because improving their urinary function will likely improve their symptoms, anxiety, concern. Enhancing sexual function, enhancing erectile function is something that most of our patients are absolutely delighted about. And the idea of not losing ejaculatory function, although at first glance you'd say, well, what's the big deal? So the guy isn't having ejaculation. Well, for our patients their whole lives, sexual activity with their partner or even sexual activity as a solo activity with masturbation or self-stimulation, ejaculation was when they knew they had ended their sexual activity. Without the ejaculation, it really is an incomplete act. And I can tell you, having done many studies in men with premature ejaculation, where we actually quantified the impact of change in ejaculation, has a huge impact on quality of sexual response cycle. So loss of ejaculation has a meaningful and measurable negative impact on sexual pleasure. So let me just summarize what I've said, that I think this fixed dose combination is a huge advance. I think it provides greater and faster improvement in urinary symptoms, both whether you measure the International Prostate Symptom Score or measure flow rates. The improvement in erectile function, even among those men who say they don't have ED, is really quite significant. And most of your men who will come in who will say, I want something for my lower urinary tract symptoms and you give them the fixed dose combination, when you see them in follow-up and ask them, I'm sure they'll say their erections are much better than they had been for many years. It really is ideally suited to that man under age 60, but certainly is also appropriate for the patient who's older, who may still want to retain their sexual capacity or may want some improvement in how they're functioning in the bedroom. It really is a nice treatment option for those men with BPH who have had only a partial response to alpha blocker and aren't interested in going in combination therapy with a 5-alpha reductase inhibitor, waiting 6 months, and maybe having more sexual dysfunction. The safety profile, the tolerability profile, and from a hemodynamic standpoint, it really is quite safe. So, I think this is something very important for the Indian population, for us as urologists, and what we can offer our patients in the future. The idea that certainly combination with lifestyle changes, improvement in diet, health, exercise, but also co-administration of pharmacological therapy is something very important. Excuse me. So the key takeaways are really, I think that targeting the younger man under age 60 who is interested in retaining sexual activity or wants to improve sexual activity, but has lower urinary tract symptoms as his major presenting complaint is really a nice advance. The idea of this fixed dose combination is wonderful, and I totally agree with the company that the 10 milligrams alfusis and 5 milligrams of tadalafil is the right dose, that the man will have an improvement in urinary flow, lessening of his urinary symptoms, and enhancement in erectile function, that lifestyle modification and patient education are really important. So, Dr. Pandey, at this point, I'm not sure if you want to carry on with some additional cases, and I'll let you do your talk, and then maybe if we have time, I can come back and do my cases, or would you prefer that I do the cases that I have now as well?
So, Professor Brock, thank you so much for taking this enormity of the data that you had and the disease process, which is touching human lives, especially young men in India, Canada, and worldwide in this 2024 and before this. I suggest we go to the cases because that will stimulate a lot of our younger colleagues who are in the audience in various cities, which will go center by center with the moderators of those cities. And you will have a huge audience of questions coming up. I can see them popping out on my chat box here. So I suggest take those cases that you have, few of them, so that we stimulate ourselves to the next level, that we have already seen the data and we understand that the prevalence of young men with this combined LUTS and ED is gross and huge. So go ahead, sir.
Wonderful. Okay, so the first case I had, which I think is a prototypical case, and in fact, it's a real case of a man that I have. He's 45. He's married. Like many Canadians, he's a little overweight. He has an increased level of cholesterol, and he does have borderline hypertension. He came to me because he's now getting up nightly once to void, and he has mild hesitancy and occasional urgency. I started him on an alpha blocker, but he said that, doc, my urinary symptoms are a little better, but it's a real bitch because I have nasal congestion and I've lost my ejaculation. And he's not happy with me. He said, what else can I offer him? What else is available to him? So, well, I talked to him about 5-alpha reductase inhibitors. His prostate was fairly large. And I had a PSA for him, and it measured at 1.9, which would be, roughly a 30-gram prostate or so. And there's no family history of prostate cancer there. And I said, we could put you on a 5-alpha reductase inhibitor. I can put you on either dutasteride or finasteride. It'll take about 6 months to be effective, but it'll shrink your prostate. And he said, is it going to cause any sexual dysfunction? I said, well, yes. There's a significant issue of sexual dysfunction. Probably 2 or 3% will have some erectile dysfunction, but I can tell you that a very high number of men will complain of loss of ejaculation or a decrease in ejaculatory volume. And I said, there's also, although I don't believe it, it's real, there's a significant number of younger men, particularly, who do complain of some persisting sexual dysfunction after 5-ARI exposure. So he said, doctor, I'm not willing to take that risk. What else can we do? I said, well, I can do a small procedure for you where I inject steam into your prostate. And he said, well, tell me about that. And I explained how Rezum worked. And he said, well, that currently in Canada is not covered, and it's $6,000. And it means there is some recovery, and he has to have a catheter for about a week typically. So he decided he didn't want to do that. I did talk to him about use of tadalafil monotherapy. In fact, that's what he ended up doing. He went on to tadalafil monotherapy, and he came back a little while. He said his erections are great. He has total ejaculation, but he doesn't feel he's really happy with the degree of improvement he's achieved in terms of his lower urinary tract symptoms. So we went ahead, and I put him on the combination, although it was two separate prescriptions, 5 milligrams of tadalafil daily and alfucisin Zatral on 10 milligrams on a daily basis, and he was delighted. So to me, that was a nice case because it really did show in the real world what happens to my own patient population, that it's a nice solution for this guy, and we're now a couple of years out, and he's still on the combination and happy with that. The second case I wanted us just to think about is a bit of an older man. He's 55. He's married. He's had erectile dysfunction now for 5 years. And he's been using a PDE5 inhibitor. He's been using a Viagra, sildenafil, 100 milligrams with good effect. But he sees me now, and he starts saying that, the erections are okay. They work well. He doesn't really like the idea of having to take a pill an hour before he wants to have sex with his partner, having an empty stomach because he finds that if he has food, he doesn't have as significant an improvement in his erectile function with the sildenafil. His digital rectal examination and PSA were normal. And so the question for the audience is, what do you do for a man like this? What is his treatment options? Would you put him on tadalafil monotherapy? Would you consider looking at an alpha blocker combination with tadalafil, that fixed dose combination we talked about, or something else? So, I can tell you that what I would do, but I'd love to have the audience. So these questions and these cases really are just to spur some of your thoughts, impressions. And I always find after I have a medical meeting where there's new data presented, I like to have an image of who the ideal patient would be when I start my clinics the next week or the next day after the presentation. And so to me, I think in this situation, it's very clear. My view would be it's that man under 60 who comes in with lower urinary tract symptoms, has some degree of erectile dysfunction, or is worried he may get some sexual dysfunction, or wants sexual function enhancement or preservation. And the fixed dose combination would likely treat both of those, improve urinary flow, speed up how quickly he responds, more significantly enhance quality of life. And so I think that's where that ideal patient really would be. So I'll pass it back to you, Dr. Pandey, at this point.
Thank you so much. This was like taking the thunder on two subjects together, and it feels good. Thank you so much for taking it passionately because you have been working on them. So the question here is, are young men living with dilemmas of two progressive complaints that they have in boardroom and bedroom? Or it's time to leave these two dilemmas because they are seeing urologists in this shining country, India. And thank you for the pioneering work that you've taken forward. We will just do a small housekeeping, and then I proceed further with a short case, which will help me to get more questions that I stimulate me and everybody in this audience to ask questions to you and to us to each other and look at answering your second question too. So the small housekeeping before I come to a short presentation is we have some centers which are live and could be on focus, where moderators could help us from the question on those live centers. And we are happy to get questions from various cities, like somebody from Coimbatore just posted a wonderful question. So we'll come on a rotation center by center, starting from Chandigarh in few minutes time. And we'll go to the moderators to help us out of any questions coming from those centers for Dr. Brock. And we'll brainstorm this important aspect to take it forward around. So the prevalence of young and needy on this combined entity of living with this is obviously a situation that we take forward around. Professor Brock, allow me to present one case of a similar kind of situation where modern young men would bend it like Beckham. It is for us, urologists, and I gather everybody in India is young. When we meet up in the Urology Society of India, we are only changing our age by cutting birthday cakes, but we all are young, and so are our young men. But gladly you define that very young men who actually are needy and who deserve to be taken forward to the logical conclusion rather than letting them be on a suboptimal therapy. So one young man with LUTs or with two entities is what we would discuss in a short way. And therefore, we stimulate and provoke our colleagues to be asking questions into the dilemmas that we have when we look at asking this young man what happens. I bring greetings from Team Urology, Dr. Ismail Attar, Dr. Shyam Verma, and colleagues from the Kokilaben Dhirubhai Ambani Hospital. And with respect to everybody in this audience, pan country, Dr. Brock, you are live to close to a few thousand colleagues on a weekend evening. Many of them are still completing their work and are on the mobile phone. We're looking at every life matters and at improving an attempt to improve the quality of life of individuals. Where possibly in India, I take this from your presentation that is it possible that our young men with LUTs designated to a suboptimal therapy? That means the question is, are they relegated to a moderate therapy rather than the best that they should get in the prime of life? Is there an anxiety of complications that they may happen? And I just got a clue from you that though we have had a great evolution on the subject, we have great expertise with our colleagues in the audience who do practice combination therapy or solar therapy, depending on the need of the hour. We have got the experience now with the guidelines and best clinical practices to match the expectations of young men who bend us like Beckham with complaints that are obviously difficult sometimes to take in forward. But obviously the endurance of this subject has now come to fore because we need to look at monotherapy for the last 2 decades for that drug called A for Apple, which you mentioned in details for the prostate and its neighbors has not been possibly the best for everyone because many of them could have been better. But as I knew that our awareness was on the lesser side. Our awareness has only grown better because of the evidence that we have. Our goalposts have changed partly because of the pioneering work with many senior colleagues in our country, including your work on tadalafil, the wonderful second slide showing the dose finding study, 2.5, 5, 10, and 20. And 5 became the optimal dose for the LUTs compared to 10 and 20 for young men requiring therapy between the thighs on the bedroom. So are our young men stuck with what we can offer in the past compared to what we'll offer in the future because it didn't have anything beyond what our eyes could see? In other words, a short case, adding on to your case around in 2023, one Mr. K, 47 years, busy banker in this country, which is financially getting stronger. Finally, he understood his need for the new R. And that's visible on the very important aspect of the pictogram, which is visible that he was young, he was capable before in his last 20 years, but he was failing progressively. And down and out in 2023, when he came in around, he was hesitant all the time before in his lifetime and hesitant now too. What he used to do is, like all Indian young men would be scared and probably scared of going anywhere, but go off the counter, buy the medicines in need and probably fulfill their needs for themselves and their partner. He was failing on that. And he was also failing in other aspects of the flow, which we are discussing on a Friday evening flow session in the Men's Flow Summit. When we take a history, we always examine all men in the bed. And when we do that under the undergarments, a deeper questioning comes in with some short questions on, do you also have anything to do with urination? So we asked that question because he came with ED. He said, okay, completely fine. I'm okay with daytime warding. But Dr. Pandey, because you're asking me, it takes a little longer to start when I get up at night or get up in the morning. So when I get up a little longer hours in the bed, then I probably find it a little difficult. It takes longer when I'm full in this long drives of the traffic jams, which we have in this maximum city of Mumbai. He carries an ultrasound report which shows 24 grams prostate post-word STD of 60 ml. I didn't see a PSA report there. And he was not very keen for me to getting into the discussion of examination of LUTs because he said, that's all looking good, but I have been failing and now I've been being hammered on the bedroom. So he also incidentally in his records shows that he had stopped this wonderful drug A for Apple a month after its use because he didn't feel the need. He didn't feel the need about this wonderful drug A for Apple, which came 20 years ago and was looking at young male LUTs to be treated around. This was probably his banking profile and his health checkup, which showed that his prostate is 24 grams. He didn't feel much need. So looking at the need for his R, we commenced on his therapy. We put him on tadalafil 5 milligram daily. We put him on that because he was desirous of performance few times a week as demanded in the bed. He had no major comorbids compared to your patients at 47 and 55 who had comorbid pictures around. So he was looking young, fit, in needy situations around because he was keen to get better on this front only. So that's what it was. I said, if that is what it is, can we just complete the urological examination, looking at an examination point of view, looking at a uroflowmetry, something which I rate as an ECG of the bladder. Like we don't open the heart to see the heart. We just do an ECG. We know you go left and right. Similarly, we look at you, whether you could pass the examination or you're looking at it. He looked to me on his nomograms around with full bladder that he said 277 ml with a residue of 40 ml. His flow was 11.6 Qmax with that prolonged curve that you see. He agreed to all that. He said, Doc, I am just needy enough and let me go. And we were happy enough. So we said, we'll follow you monthly and we'll watch you. So imagine what he did. Follow-up 1. He narrates progressive satisfaction and his capabilities in the bedroom as if he's a young man again. And that's wonderful. That's what we want him to feel. And a follow-up 2 came up, and that was what is interesting. And that's where I'll ask you a question before we go to our colleagues pan country. So he said there was a spontaneous confession of him of improved performance at nights. I'm not talking about the bedroom. I'm talking about the taking a longer time to pass urine had actually gone down. He was looking much better. That word hesitancy was becoming shorter and shorter for him. And the traffic jams, not the jams per se, but beyond the jams, when he would come back with a pregnant bladder, he would still be able to pass urine better compared to what he used to pass. He said, what have you done to me? I said, that's completely fine. So he was now keen to get his flow better. Imagine, we provoked him, we asked him, he had stopped A for apple at that point in time. And now we understand that some other drug is doing wonders to him. So perhaps men have something which is more significant compared to other. They come and complain to you, me, and our colleagues and seniors in this wonderful audience, and we take it forward. We don't leave them alone. We look at their safety, we look at their long term. So decision was made about this man, the medicines, which we talk about a combination therapy in your presentation of the fixed dose combination, and now he is motivated. So we combined him with alfuzosin, which was A for apple, the drug I mentioned in the acronym then, with tadalafil 5 milligrams, which is on as a fixed duct combination, which came to our country last year in the month of July and was attempted and called for a follow-up. And believe me, this time, I said a blanket, gentle follow-up, no big rush. You can come in 2 months and 4 months' time. He runs back in 4 weeks' time to narrate his woes of the past in the boardroom and bedroom. He says, Dr. Pandey, Dr. Brock, what was this? All these months, I was probably telling somebody or telling to myself, I was living in a dream world which I was aiming for but never got it. And he says, can I have one more uroflowmetry? I said, why? He says, I think I've improved. And Indian men who come to urologists today carry this big files, thick files of reports after reports. And it's all reports that motivate them. It probably is a progressive entity that doesn't motivate them too much. And look at his uroflow at this point in time. He's just crossing the border. He's just crossing the border there with a 14.6 ml per second. 471 ml, he's able to hold much. He's able to pass better. So I was just trying to stimulate myself to look at Indians and our colleagues who are younger in that working age group. You talked about 40 to 59, who are that working force and probably are making a large population. The enormity of these people actually is huge. It's all about they probably living a dream of not being able to get the right therapy, and that's difficult. So Dr. Brock, I come to the last slide, driving inspiration from your presentation, driving inspiration from our friend Atul Gawande in United States, from these 2 important books that all of us must read. One is called Better, other is called Complications. So you rightly said, better minus complications is what all young men expect. And to make them better minus complications, we still follow the Hippocratic Oath. We continue to evolve better and better because as doctors, we keen to look into the world over, men don't complain. They are underreported, underdiagnosed, undertreated, and understudied because they continue to live with this problem. So truly a challenge, a dream. It's a story of human ambition, of the kind of research, the kind of jugaad on the combination that we make and we reincarnating ourselves for our younger men. We know that all elderly would one fine day take the medicine for a longer time. If they don't follow up, they'll end up in a trap of from medication to surgical and to minimally invasive therapy. So it's time to take young men's LUTs to front row seat. From our colleague audience across, Dr. Brock, a question from my side before we go to our moderators in the city of Chandigarh, and then we rotate center by center as more and more questions crop up around. Dr. Brock, across the consult table where I'm sitting right now at the Kokilaben Hospital, rarely we get a man complaining of both the entities with significant similar kind of a complaint. That means I'm very bad in the bed and very bad in the bedroom. They come with one entity. It is us as urologists in this country who actually ask questions at that point in time, maybe examine them and ask questions, or maybe on follow-up ask questions. And then believe me, it is like they had one which was significant, other was always there, like this gentleman which I attempted to show you, which means that there is bothersome symptomatic LUTs on one side and this bothersome capability in the bed, which is progressively changing as his black hair turns gray or probably is still very young. Is it the similar situation for the large group of people that you talked about. And also, you did allude to the Indian study where you talked about 30 to 39 years. And that's a great one. 25 years old data from 1997, which talks from India that 40 to 49 years individuals had moderate to severe LUTs, 25%, and 50 to 59 years at 37% moderate to severe LUTs. Did it mean that that study and we all forgot about the younger men in 30 to 39 years young, which you did allude to in your presentation, that you, when you get them, you probably present. So your answer to this, and then I'll rotate it across my colleagues in various cities on this weekend evening. So let's flow on the Friday evening. Go ahead, sir.
Saturday evening, right?
Oh, sorry, Saturday evening. Yes. Sorry.
Yes. Okay. Yeah. Just make sure I have it right.
Yeah.
So what you bring up is a great point. I think that the pathology is linked. And that's why we see so many men who have lower urinary tract symptoms and erectile dysfunction, because I think it is through the same pathway, whether it's vasculogenic, neurogenic, or it's to do with neurotransmitter levels that are not sufficient. But the comorbid patient is incredibly common. In Canada, and it may be the same in India, is that most of our men don't want to talk about sexual function. They don't want to describe that they're having problems in the bedroom. They're much more common and much more comfortable talking about LUTs and talking about the fact that their urinary system is not as good as they'd like it to be. But if you were to ask those men who come in with lower urinary tract symptoms about the incidence of erection problems or loss of erection, you'll find that it'll be a surprisingly high number. So, I think that it really is a common pathway. And your point about the younger men, particularly the 30 to 39, it is really, really common. And what's interesting also is that even among those guys who say, well, it's not as good as it used to be, I can still function, I can still get an erection, it's still pretty good. When you give them the opportunity to try the medication, they come back and they say, wow, that was different. It is much better. I didn't realize how bad it was until I had the treatment. And I think that's human nature. I play tennis all the time, or racket sports in general, and I think I'm doing okay. But when I look back at how I played racket sports 20 years ago, it's not the same. And I think we're the same in the bedroom, that a progressive loss of function is not recognized. And when you provide them with a safe, effective alternative that would give them both the capacity in the bedroom and improving urinary tract function, I think they really recognize it and appreciate it. And you'll get the feedback from your patients that tell you just that. I think that you're absolutely correct that this is something that we've kind of ignored the younger population. And it's just that we deal so often with the more severe older population, but we can effectively manage the younger ones too and improve their quality of life. And why would we not want to do that?
Great. So we'll have wonderful questions from the answer you gave in around our colleagues, my teachers, and my colleagues are watching you from all over. We're going to go to Center Chandigarh, so we could have a spotlight on few of the centers which actually are on. And there is one question which has come from Dr. Sudhir. So Sudhir, I'm actually going to ask your question to Dr. Brock, and then there could be other questions too. Dr. Sudhir, you can actually ask that. Go ahead.
Thank you so much, sir. That's a great talk. We are happy to enjoy the nice presentation from Professor Gerald Brock. So we have multiple questions anyway. I am Dr. Sudhir. I am additional professor in urology from BGI Chandigarh. Out of that, I am asking just two questions from my side. One question is most of the patients of BPH, who come to the clinic are many a times they have a larger gland. And all these patients, many a times they are started on a combination therapy of alpha blocker and a 5-alpha reductase inhibitors. And we all know that the fact that long-term usage of these drugs over a period of time are known to cause decreased chance of acute urinary retention, and the need for surgery also would be decreased. So my question to Dr. Gerald Brock was whether this combination of an alpha blocker with 5-alpha reductase inhibitor, based on the amount of experience you have on the long term, does it reduce the chance of the main final outcomes in terms of acute urinary retentions and also the need for surgery? And the second question which I want to ask was, let us say a patient comes to me without any erectile dysfunction with LUTs, and I put him on combination of combination of PDE5 inhibitors and also an alpha blocker. If on the long term, does using this PDE5 inhibitors lead to drug dependency, because many a times patients, on long term, they miss the drugs in between. So can that lead to drug dependency in terms of erectile function is concerned? Unless and until they take medication, they doesn't have good erection, Can such situation arise in such patients?
Excellent questions. Thank you for that. So, as you know, the data on 5-alpha reductase inhibitors and reduction in need for surgery and incidence of retention is highly variable. Even in the studies that show really the most significant effect, it really is a very small percentage of patients that will ever go on to need to have surgery or have retention, in the order of less than 10%, even in the studies that show a significant number. So the idea of an alpha blocker and a 5-alpha reductase inhibitor as a combination to reduce the need for surgery, need for retention, was really a study that was promoted by the pharmaceutical companies to try and show there's a reason to have 5-alpha reductase inhibitors. When we combine an alpha blocker and a PDE5 inhibitor, we wouldn't expect we would get a reduction in the size of the prostate in the same way that a 5-alpha reductase inhibitor would. And we wouldn't expect that we would see that sort of same effect as a 5-ARI. So to summarize, my answer is, I don't think if they did the study on the fixed dose combination, we would see the same sort of effect as a 5-ARI. But that effect for most patients is really not clinically meaningful, because it represents probably somewhere between 5% or so of patients who will ultimately go on to retention. It's a very, very small subgroup. Your second question, dealing with long-term use, is really about tachyphylaxis. Really that phenomenon where if you continue to take a PDE5 inhibitor, does it become less effective, or does the patient need to increase the dose over time, or does it become ineffective with long-term use? And the short answer is no, that doesn't happen. And the reason it doesn't happen is because it's a competitive inhibitor, and even though we're blocking the enzyme, we're only competitively blocking it partially. So the enzyme is still effective and still works. And the long-term data now for many, many years shows that it really continues to be as effective. It's interesting in that if you look at that long-term 1-year data, the actual improvement in outcomes, in quality of life, in IPSS scores, actually continues to get better beyond a year. So the long-term follow-ups of these studies actually show an enhancement at 1 year, 2 years, compared to at 12 or 16-week time points. So that's good news for your patients.
Thank you, Dr. Sudhir.
A chance I can ask a quick question, sir.
Please. Yeah, please.
We know that PDE5 inhibitors improve the pelvic microvasculature blood supply in terms of improving the microcirculation. And what do you think is there any possible role of these drugs, particularly in patients who had chronic prostatitis, or even I have seen some animal studies showing the PDE5 inhibitors improve the blood supply to the bladder, leading to decreased chance of overactivity in the bladder as well. So do you think that these drugs have a positive role in these situations as well?
So again, really insightful, excellent question. And you're quite right that the pelvic floor circulation is enhanced. And that is one of the putative pathways for which it works. I'm not really aware of if vascular insufficiency and prostatitis has been linked strongly. And I'm not aware of the literature related to that. But certainly it does relax the pelvic floor, and there is no harm in using a PDE5 inhibitor in the patient with prostatitis. I just don't have a really strong answer for you on that aspect of prostatitis and PDE5 inhibitor use. Dr. Pandey, do you know?
No, prostatitis and all, we have looked at data before we came to this program today, and I don't think there's any major link which has been provided on prostatitis, vascularity, PDE5 coming together. Right. Dr. Brock, his question was also regarding tachyphylaxis. We know we started a drug on the evidence on that day. The requirement of dosages may change in due course of time or over decades, but there may be no tachyphylaxis, as you rightly pointed out.
Right.
Dr.
Right.
Sudhir, allow. Yeah, sorry.
Yeah. And of course, what does happen is as patients get older, sometimes their health condition can change and can progress. But in fact, from a pharmacological standpoint, there's no loss of efficacy of the drug over time.
Thank you so much, Center Chandigarh. Thank you, Dr. Sudhir, and everybody up there. we'll move on to the next center. My left eye is on the clock, watching what is happening on a weekend evening. So let's go to Delhi. If you can spotlight on Delhi, please. Good evening, Dr. Varshney. Can we have questions from your center, please?
I think he's muted.
You're muted. Can somebody unmute Delhi center? Dr. Varshney is not audible to us. Sir, Dr. Varshney, you're not audible. Do we need to come back to Delhi center? So we'll wait for Dr. Varshney's voice over, because it's only lip sling right now. We will look at a question.
I think he was saying that he loves your jacket, Dr. Padney.
That's a destiny of somebody who wears it, kind of thing around. But I'll wait. Dr. Varshney, you can hear us. You are muted, it looks like. Apologies. Can we come back to Delhi center a shade later while it is fixed up? Can somebody put his question up there on the chat box? Allow us to come back to Delhi center a shade later when we are informed about. Can you move on to Kolkata? Friends from Kolkata, are we live with you? Kolkata, is there a voiceover out there? Can we unmute Kolkata center, please? Yes. Can we have our questions from Kolkata center? Yes, we have got few questions for you. Go ahead.
Sir, good evening. First of all, it was a wonderful, enlightening session from Dr. Brock, and you putting in at the right moments at the important clinical inputs. So it was really wonderful. Sir, one important question is that it's right that though it's not a very new topic, but perhaps it was overlooked over the last few decades. An important thing, sir, whenever the patient comes to us with such moderate to severe LUTs, is it better to go with an alpha blocker first, assess the response, and then shift on to a combination therapy, or it's better to go with all the guns going at the same time, sir? Sir, if you can share your experience with us regarding this, sir.
Dr. Brock, if you got the question right, I too have looked at the echoing happening around, but is it perhaps, he asked me about bothersome LUTs, do we start with a combination therapy straight away, or we look at one therapy, add on therapies according to the de novo follow-ups, and we take it forward from there?
Thank you very much. Yeah, there was some echoing, so I appreciate you repeating the question. So again, we're getting great questions. You know, I think that it really comes down to the art of medicine, to be honest. If a patient comes to me and he says, doctor, you know, I'm really having significant erectile dysfunction, and I ask him and his LUT symptoms are relatively minor, I think I would just start him on a PDE5 inhibitor with monotherapy. On the other hand, if he comes to me, which is quite common, and will say that his urinary symptoms are the predominant presenting cause, then I would start him on combination therapy, particularly if he has a concern about loss of erectile function or he wants erectile enhancement. So that's where I think the combination is really valuable. Now, if the guy who comes in with ED also describes to me that, yes, you know, I'm bothered at night, I'm getting up 2 or 3 times a night and my flow is slow and I take some hesitancy and urgency, at that point we'll have a discussion. The reason why I'm so willing to start the combination therapy is if you look at the side effect profile, it isn't any higher. If you look at the efficacy profile, it's significantly better. So the downside risk, when you look at risk-benefit ratio, the combination basically adds significant advantages to the patient without significant morbidity. And that's why I'm so easy to use it. Having said that, in a guy with a single problem, erectile dysfunction, who really doesn't have any lower urinary tract symptoms, I would go with the PDE5 inhibitor monotherapy.
Thank you so much. Are there any questions from Kolkata?
Thank you,
yes,
sir.
Go ahead. Are there any other questions which I could look at? Hotel Rajkuti, Sobaike Namaskar Janachi. Is there any other question? Kolkata Center. Dr. Brock, while another question comes up from Kolkata, let me see a pop-up question out here. We have this 2.5 milligrams and we have this 5 milligrams, and you did allude to dose finding 5 milligrams. You also did talk about interject that there was 2.5 milligram fixed dose combination not required by the company here or maybe anywhere in the world. So I gather that 5 milligram could be a blanket dose, like a 10 milligram alfuzosin is all that is available. There's no 5 milligram and 15 milligram alfuzosin as a finding study in that era, which came reinvented 20 years ago as an extended release medication after the old wine in new bottle. So when I look at that, 2.5 milligram does not have any meaning at this point in time compared to 5 milligram. Some of our colleagues have been a little cautious in the country, starting with 2.5, because there was always this worry and teaching in that era when these medicines came up. On one side, sildenafil, other side, the alpha blockers, keep them apart. They could probably have a combination issue, an issue about hypotension, etc., etc. Just want to little bit shed that issue about 2.5, 5 and combination.
So, great question. The data when we were looking at PDE5 inhibitors, tadalafil at various doses, it's really interesting that they actually had efficacy at just over 1 milligram of tadalafil when you take it daily, because of course it increases a little bit to 1.6 times the concentration you're taking it. So there's efficacy at 1 milligram daily or 1.25 milligram daily in terms of erectile enhancement, but not in terms of lower urinary tract symptoms. And when we look at 2.5 milligrams daily of tadalafil, again, very modest at any clinically meaningful effect on lower urinary tract symptoms. 2.5 milligrams a day for erectile dysfunction with tadalafil is actually pretty effective. It works in probably 60% of men. 5 milligrams, in contrast, has basically the same efficacy as 10 or 20 milligrams daily. Obviously, has a better side effect profile, and you don't lose very much in efficacy, and it's dramatically better than 2.5 milligrams. So when you look at risk benefit, side effects, efficacy, 5 milligrams daily for LUTS is the right dose, and really the only dose. And it's the same story with alfuzosin in terms of the 10 milligrams. So I really think that's the sweet spot. I was doing a lot of patent challenges around the world with tadalafil over the last decade, and I can tell you that many of the companies looked at the various early data and really showed that even at very, very low doses, these drugs work for erectile function enhancement. But the LUTS story, which is really the important one here, really 5 milligrams is the right data.
Thank you so much. Coming back, are there any more questions at Hotel Rajkotir in Kolkata? We will move forward from Kolkata and go back to Delhi. If Delhi has been unmuted, please. Dr. Varshney, you and the team had questions. Could somebody unmute Delhi and help us out? Yes. Can somebody we can take questions from Delhi. Yes, please.
Dr. Greetings from New Delhi, Dr. Sanjay and Dr. Brock. I think now you can hear us. And we are all listening to a marvelous talk by both of you, and it has been mesmerizing. And the questions, I think the chat box, they have typed out the questions. The audience is interested in knowing that if the patient has only LUTS, no ED, do you give combination to the patient, and if you give them, how long do you give them, and when would you like to switch back to monotherapy if at all? That is one question. The second question is that whether these patients, what is the percentage of patients who would not be suitable for this combination, and they will get, they will have to withdraw this combination if at all. So, will the side effect profile, contraindications, and when do you stop ultimately? So, something we would like to be enlightened about.
Thank you very much. I'm not sure I caught all the questions, so Dr. Pandey, please help me out here if I missed something. The second question I'll start with first is who's not suitable or contraindications. So certainly anybody that cannot take a PDE5 inhibitor would be not suitable for this fixed dose combination. And that is becoming fewer and fewer men because less and less people are being prescribed nitroglycerin. And of course, we all know of the interaction between nitroglycerin and a PDE5 inhibitor. But because nitroglycerins have been shown not to be protective for cardiovascular insufficiency, they're being used very, very less often in many parts of the world. Any man that can't have sexual activity because of cardiovascular reserve also would not be a good candidate for this. Having said that, you don't need to do a cardiovascular workup or a stress test or anything like that to use the fixed dose combination. It is absolutely safe for men to use 5 milligrams of tadalafil in combination with an alpha blocker, because we know there really is very little in the way of vascular effects, cardiovascular insult. And so in the past, we, at some point early on in the early 2000s, a year or two after approval of these drugs, there was a big concern about cardiovascular impact of PDE5 inhibitors. We now know, as I mentioned from the Cloner study, that it's actually cardioprotective. And it's cardioprotective actually consistent with how much PDE5 inhibitor you take. So the men that took more PDE5 inhibitor actually had more cardioprotection based on Cloner's work and many other studies. So the big group would be, if there's an absolute contraindication, and that would be somebody with, some nitroglycerin dependency, if they do have a concern where they may need nitro in the future. But short of that, there really aren't very many other than some unusual complications. We knew that with sildenafil and vardenafil, there was a concern about crossover with PDE6. That's not an issue with tadalafil in terms of any ocular issues. There was a concern at one point about some hearing loss, and that really has gone by the wayside as well. So really, I think it is just that one group on nitroglycerin that I'd be concerned with. And because it is such a small dose, even patients with renal insufficiency or some hepatic insufficiency, unless they have hepatic failure, would not be a concern for use of this 5 milligram dose either. I think the other question that you had asked was about the man who doesn't have any erectile dysfunction and whether the fixed dose combination has value in that individual. So I would answer the question in two ways. First of all, I think it's a wonderful case and wonderful question because it represents probably a pretty significant group of men, especially younger men. So the man likely may have ED and not even recognize it. That would be my first thing. And the second is that in many of these men who truly have no erectile dysfunction, the efficacy in terms of improving his LUT symptoms will be better on the fixed combination than it would be with either agent alone. So in that man who really has no erectile dysfunction, giving him the fixed dose combination, we would predict that he'll get a better response more quickly on the fixed dose combination than he would on an alpha blocker alone. And then if we look at the contrast, the side effects that we could expect from the fixed dose combination are no greater than either of the two agents independently as monotherapy. So apart from cost, and I'm not aware of what the cost of the tablet is in India, I don't see a reason not to go with fixed dose combination because you'll likely have a better response and a sooner response with the combination. Dr. Pandey?
So Dr. Brock, it's about a uroflowmetry graph or a curve giving us a view which is more commonly probably looked at from the alpha blocker point of view compared to a man feeling much better on the IPSS symptom score on the tadalafil group. Is that what probably looks like? And we look at the combination of his results on both sides when you look at combination therapy. Okay. I have a question all the time in my life is about sildenafil came first.
Yes.
Why did the world and you and organizers looked at tadalafil as a drug of 1,000, looking at 2.5, 5, 10, and 20, compared to sildenafil 25, 50, 100, etc.? Just because that drug was probably the highest sold drug at the level of mankind before tadalafil came in around. So why did you choose Cinderella or Cleopatra or the other way?
Oh, yeah, well, it's very standard. You do phase 2 dose finding studies in any clinical development program. And what you do is you look at the inhibition that you get at the molecule level and to actually see what different doses will cause in terms of efficacy. And so it's always an efficacy side effect study that's done in phase 2. And it turned out that this drug was much more effective at inhibiting the PDE5 enzyme than sildenafil was. And so smaller doses were able to do it. When they did explore in the dose ranging studies out to 100 milligrams of tadalafil taken on a daily basis for 3 weeks, so 20 times this dose every day for 3 weeks, it was still well tolerated. The visual side effects actually started to show, and they did have some muscle aches and pains, but the efficacy in terms of improving erectile function weren't dramatically better than the 20 milligram dose taken on demand or the 5 milligram dose taken every day. So on that basis, side effect profile, efficacy, safety, that's how they arranged the dosing.
Thank you. Dr. Brock, we would take leave from the Delhi center. You could see the entire capital out there. You can see the entire center saluting you from that place around. And if there are no questions from Delhi, which I would look into the chat box which the team would send, can we move to the Mumbai center at the Hotel Taj? And could you look at Taj as a center in Mumbai, giving us an idea of questions if there are any? So, can we have any questions from which have not been answered or which Dr. Brock has not missed out? Yes, sir. Go ahead.
Hi, Sanjay.
Good evening. Go ahead, sir.
Dr. Brock, welcome to this center. Now, I have two questions. One, that first of all, I think the definition of young people must change. Because I think in modern practice, we see patients in age of 70 and even sometimes 80 are bothered about erectile dysfunction with LUTS. So I think that goalpost has to change. And many times these people, as you very rightly said, may not be able to express their problem, but they do have this combination of problem. So of course, you talked about the safety profile, but many times alfuzosin is a little drug of concern because some of the patients do complain of sometimes chest discomfort or uneasiness. So your experience on alfuzosin, even in young patients, we have seen that. So it's not as safe as we thought earlier. They do have sometimes some sort of symptoms related to cardiac cardiac type of symptoms. So first, your comments on that. My second question is, once you start, now these are young patients in 45 and 50s. Once you start the treatment, would you continue for a long time? Or you would reassess after a certain period and then decide to continue or not to continue? Or you suggest that they have to take a lifelong? Because many times people believe that this medication has to be taken for a lifelong. But I strongly believe that many times intermittent therapy do help. So your experience as far as this issue is concerned. Thank you very much.
Great questions. Thank you very much. So I totally agree with you. I just turned over 60 myself. I still consider myself young. So I would agree that we should look at changing the young to less than 80. But, you know, I think that I may have some pushback. In terms of safety, I think what's really important for us to understand is that all drugs have a side effect profile. And alfuzosin and tadalafil are no different than any other drug. The difference is, I think, what we need to consider and really decide on what we use is based on tolerability and safety. And so the difference between tolerability and safety is I consider safety when someone has a true, dangerous, or worrisome side effect. Cardiovascular compromise, shortness of breath, significant myalgias, alteration in renal function, alteration in hepatic function. Those would be safety concerns. And so my point is that you're absolutely correct. Like all drugs, alfuzosin and tadalafil have some side effects. And for some patients, a relatively small number, there may be some tolerability issues. And so if that gentleman has nasal congestion or some chest discomfort or something else, then that's not the right drug for that individual. But it doesn't represent a safety concern. And the data on safety is very strong and very clear. You know, I think that the duration of therapy is where the art of medicine comes in. And each of us probably have a slightly different approach. I can tell you that what I do with my patients is I start them on a therapy. I then typically, depending on what the particular therapeutic area is, will decide when I need to see them for an assessment of efficacy, safety, tolerability of that treatment. For BPH LUTS ED, I would typically see them at 3 months. And I would ask them, how are they doing? They give me their feedback, and then I would see them in a year. And I would see them on an annual basis for a couple of years. If they're stable, they're happy, and things are going along swimmingly, then typically I discharge them from my practice, and they get followed by their family doctor. It may be different in India, it may be different in your own practices. But this is something that I would envision would likely be lifelong, just as it would be for hypertension or hypercholesterolemia. And then in those patients who become refractory to therapy or don't want to continue on with medical management, at that point we would offer them some surgical options or other therapeutic approaches. But generally, I explain to them that your prostate is going to be a problem with your prostate, and you're probably going to be on this drug lifelong. I really appreciate your insights and on your experience with intermittent therapy. And I think if that's working for you, that's fantastic. And if your patients enjoy that approach, then more power to you. In my experience, most of my patients, when I stop their therapy, they do become symptomatic quite quickly and revert back to the therapy and want to continue on with their medication. Did I answer your question?
Yes. So, Dr. Brock, did you say that you would not look at a de-escalation therapy like the MTOP study, relegating to one drug, which could probably be beneficial for both the aspects in due course of time for younger men, or because they've got the best of the results, you would continue to be on the therapy till they complain or till we require a high dose?
Yes. So if I do put them on combination therapy with a 5-alpha reductase inhibitor, the idea would be that if they're on an alpha blocker and a 5-alpha reductase inhibitor, yes, I would often take them off the alpha blocker in due course. Because I've caused a structural change to their prostate, and their symptom relief probably would be persistent just on the 5-ARI alone. If, on the other hand, you stop the 5-ARI and keep on the alpha blocker, likely they have recurrence of their symptoms in the next 6 to 12 months. With this combination of an alpha blocker and a 5-alpha reductase inhibitor, a PDE5 inhibitor, you wouldn't expect that if you pulled one of the agents away or stopped therapy, that they'd have persisting improvement in their symptom relief once they're off the drug.
True. Dr. Umesh Oza sir was actually pointing out to a large body of practice and the kind of issues that we face where men don't accept any complication, including those which could be chest and dizziness, and which is not unknown in today's world too for the drug alfizocin. Are there any more questions from the Mumbai Center?
I am looking at Dr. Pandey. Sorry, Sanjay. Just there's one little clinical pearl that I often use that may be helpful to some of the people in the audience. For the patients, of course, I explain to them what the likely side effects they may experience will be. And if they know ahead of time, they typically understand that, it's an expected side effect and it's less worrisome to them. The one that is particularly important to warn them about before is that they may experience facial flushing. Facial flushing, of course, is a well-recognized side effect of all PDE5 inhibitors. And what I tell them is that when you see, and it's much less common with 5 milligrams of sildenafil because they have a steady level. And it typically really only manifests with short-acting PDE5 inhibitors when you, about an hour after you take sildenafil, or maybe a little shorter after vardenafil or vanafil. But you can have it, of course, with tadalafil as well. And I tell them, if you notice facial flushing, that's a sign the drug is really working well. And it tells you that's really go time, that your erections are going to be fantastic, and that's the maximum time. So they look at that facial flushing as a sign the drug is really effective, and I never get complaints about facial flushing because of that.
So did you tell us, and which we also say that the additional effects which happen around are good signs, but they are rated as side effect for the society, and therefore men come back saying this drug causes this and causes that. For example, if somebody has ejaculatory and erectile dysfunction, it possibly is a pure side effect to him compared to the great effect you gave him over the last few days of improved flow. So it's not uncommon for that situation. Completely fine.
Absolutely. Agreed.
Allow me to move forward, Dr. Oza, if I can move forward from your center and move to the city of Bangalore. Colleagues in Bangalore, good evening to all of you. Are there any, can we have Bangalore Center unmuted? Yes, please.
Good evening from Bangalore. I'm Group Captain Sivarama Krishna. We have Dr. Ramesh also here, and other faculty, and a lot of students here too. Good evening, Dr. Gerald. I hope you can hear me.
Perfectly. Thank you.
Great. What time is it there? I think it's breakfast time.
No, it's noon.
Oh, great. I personally have a question to ask you. In my practice, as of now, people reporting with looks suggestive of benign prostatic hyperplasia, even if they're coming in the age of around mid-40s, I find that the first necessary investigation, apart from working up for benign prostatic hyperplasia, is workup for diabetes. My question to you is, how common is it in your country? The second thing I wanted to ask you was, these people do, like you said, in India also, people are very secretive about revealing their bedroom functionality. You really actually have to be friendly with them and talk to them for a while before they tell you whether the little soldier is functioning and he is able to salute or not. But what I have found in my practice is that if I correct the blood sugars and treat the benign prostatic hyperplasia, if it is mild or moderate, with an alpha blocker, if you control the blood sugar tightly, their erectile function improves. Is that the same case with your population too? And the third thing I wanted to say was, I'm very fond of a drug called naftopidil. The Japanese are also fond of, as a matter of fact, and there's not much literature, as I am aware, in the Western literature. But naftopidil at a dose of 50 milligrams does not seem to cause retrograde ejaculation, which is a very distressing symptom when you are using alpha blockers. What is your opinion on these three questions? Diabetes, control of diabetes will help with just alpha blockers, and is there any experience of using naftopidil?
So I don't have any experience with naftopidil. I'm sorry, I really don't, and perhaps Dr. Pandey does. In terms of diabetes, you bring up an excellent point. And I think that we have to be holistic in our approach to the patient that comes to us, whether they're younger or older, and finding an underlying cause is really the goal of all of our investigations. So if a man comes in, of course, I would recommend doing the standard workup with history physical. The lab test that we do, of course, we would do a urinalysis, and in that point, we would likely find that he's spilling sugar in his urine if he's an uncontrolled and undiagnosed diabetic. We would also do a blood panel, and I routinely would do, creatinine, blood sugar as well. So treating the sugar, of course, is critical because, as the students in the room may or may not know, all of the urologists know, it causes an osmotic diuresis, and it would cause a lot of urgency frequency. The other thing that's interesting, once we're talking about these newly diagnosed medical conditions, underlying conditions, because I think it's a great topic to bring up, is that in my career, I've made probably 50 or 100 diagnoses of multiple sclerosis. When young men come to me and they complain of new onset of erectile dysfunction, that oftentimes voiding dysfunction in undiagnosed multiple sclerosis patients can also be a presenting symptom, and erectile dysfunction can be. So it's important for your trainees in the room to always remember the diabetes point that you brought out, and also MS. I'm not sure what the prevalence of MS is in India, but it is actually extraordinarily high in Canada. So I would agree with you that I think it's important to treat it. I find that, at the end of the day, as clinicians, you have to decide in combination with a discussion with your patient what really works best for them. And if the alpha blocker is monotherapy, they're happy with it, and you're happy with it, then that's wonderful. The point of the presentation today was really just to say that for India now, there's a new option that may be advantage in terms of efficacy, side effect profile, to many of the patients where a combination as a single pill exists. It isn't going to be right for everybody, and it won't be every urologist's first choice. But I think it's nice that there's a new option. It's a drug combination that shows increased efficacy and speed of onset compared to monotherapy. And I think for some patients, it will be a significant advance.
Thank you, Dr. Brock. That was Group Captain actually, giving us the lead what Indian urologist does. Very deep practice, practically oriented, and looking into that confidence building, which was a discussion, counseling, and creativity therefore comes around. That's how deep Dr. Brock is, the kind of questions that you take around for the kind of a wonderful practice that happens in India with the very depth of the subject which has gone in. I must point out that the old order changes giving place to new. Sadly, many drugs are getting relegated to the past. Trospium chloride, a wonderful drug for many of our senior colleagues, is off the market completely. Naftopril, similarly, at 50 and 75 milligrams is a shade available for a lot of us who use it as a combination second alpha blocker 2 of the guidelines. And probably it's because we combine 2 alpha blockers in many situations around, which is again off the guidelines, off the counter around, but aspects do happen around. Friends at Bangalore, good evening to you and thank you so much. Our left eye is on the clock while we look at many questions coming in from other centers. Allow us to move on and go to the city of Hyderabad. Friends in Hyderabad, good evening. Can we unmute our Hyderabad team? Are there any more new questions that Hyderabad team would like to ask Dr. Brock? Dr. Brock, you started on the other side of noon and you're going to go to the other side of noon. You've never been so long on any talk around talking pan-country to colleagues who are deep immersion practitioners. Sir, go ahead.
Hello. Good evening from Hyderabad. This is Dr. Ravi with his colleagues. We have one question for Dr. Gerald. When the maximum flow rate with alfuzosin or any other alpha blocker is only around 2.5 ml, why do patients feel so happy and they want to continue these drugs for years together and sometimes for life? But what you see is only a very minimal increase in the flow.
You know, that's an absolutely terrific question, and you're quite right. Typically, the alpha blockers will cause roughly a 2 to 4 cc per second improvement in flow, depending on how slow the flow was at the baseline. When we first started doing research on PDE5 inhibitors for LUTS, many of the basic scientists said, you know, based on how the studies for alpha blockers were done, we believe that our PDE5 inhibitor will show similar improvements in urinary flow rates. You probably know that the first few studies that looked at LUTS with PDE5 inhibitors with tadalafil specifically did not show flow rate improvement. There was an improvement in IPSS, there was an improvement in patient satisfaction, but flow rates did not improve. Subsequent studies now show that flow rates are of the same order as the alpha blockers. And we think that that flow rate improvement in the combination is actually better than either separately. But the reason why even a small increase in flow rate would be noticeable by the patient usually is because as a percentage of their flow rate, it actually is quite significant and noticeable. Typically, it represents about a 10 to 20% improvement in baseline flow rate. And so what that means for most men is that they spend 10 to 20% less time emptying their bladder. And as a result, that's noticeable. They can actually see the difference in flow. And even though it may be just 3 cc's per second, that is actually something that they can recognize. But as a urologist, we would say, well, that's marginal, probably not significant. But at the end of the day, if it is to the patient, it is to us. Good point.
Dr. PDL and good evening, sir. Go ahead.
Hi, Sanjay. This question is to Dr. Gerald. You are talking about a young man, 45 years old, with 26 grams prostate, with LUTS or some severe LUTS. I would like to start rather on antimuscarinic drugs rather than this combination. Most of them, they settle down. So what is your... comment?
So there was some really good work done early on, maybe 15 years ago now, that looked at Detrol, that looked at the impact of urinary retention in men with lower urinary tract symptoms who are placed on an antimuscarinic anticholinergic. And they actually showed that urinary symptoms improved, urgency frequency improved, and retention rates did not increase. So I think you're absolutely correct. That's an option to treat those gentlemen. And you don't have to worry, particularly in the younger individual with a small prostate, about flipping them over into retention. So it is absolutely an option. The downside is they're not great drugs either. And they have side effects, and it might be constipation, dry mouth, dry eyes, other side effects that they'll complain with. So I'm not sure in India if mirabegron is available, and if it is, a beta-3 agonist may be another option to treat the urgency frequency symptoms, and that has a lower incidence of side effects. So again, the beauty of being a urologist is we have lots of choice.
So Dr. Brock, mirabegron came to India in 2016-17, and it's deep into the hearts of us and the kind of practices we do with mirabegron and combination therapy. Team Hyderabad, are there any more questions from Team Hyderabad, please? Yeah, so we take a last question from Team Hyderabad.
Good evening, sir. I have a case scenario for you. A 55-year-old patient with moderate LUTs, a 60 grams prostate, and mild ED. So we have three options: alpha blocker, alpha reductase inhibitor, and PDFA inhibitor. If we start him on alpha reductase inhibitor, the size reduces, risk of AUR reduces. But if we start on tadalafil, his ED will improve a bit. So is there any middle ground for him, or should we go one way or the other?
Yeah. So, I've always been curious about how unique each individual is and how poorly predictive size of prostate is to determine symptoms. And I'm sure there's lots of reasons for it we can all come up with, but the simplest answer I give to my patients is the actual size of the prostate probably doesn't determine how bad your symptoms are, because it probably doesn't define the constriction or the amount of resistance. And so that 60-gram prostate, that guy you describe having moderate degree of LUTs, would be really not very different in my mind than a guy who may have a 40-gram prostate or an 80-gram prostate. And I would go based on his symptoms much more than anything else. Now, I'm sure you're aware that if the guy has a particularly small prostate, there's really no rule for a 5-alpha reductase inhibitor. And if it's less than 40 grams or so, it probably really isn't appropriate. PSA or 30 grams, PSA of less than 1.4. But in your case, I think a discussion with the patient would be really appropriate. And I think that you're not limited to treat just one problem. I think that in that case, I likely would go with combination therapy right from the start. And I don't know that I feel the necessity to shrink his prostate, because if I can relieve his symptoms, I think I'm much better off and he'll be happier. Even if we go down the 5-ARI pathway, we're probably looking at 3 to 6 months before he gets symptom relief. So he's not going to be happy with me. And in the Canadian context, I'm not sure in India, but in the Canadian context, after 3 months of taking my drug, if I chose a 5-ARI, he's probably going to say, I need to see another urologist, because this drug he gave me is not worth anything. So I certainly would give him something to relieve his symptoms, to improve his erectile function. And in my world, that would be an alpha blocker and a PDE5 inhibitor. If he was concerned about wanting his prostate smaller, some guys in Canada are very data driven, and they come to me on referral from a family doctor, and they have a PSA of 4.4 and an ultrasound that shows a prostate of 60 grams, and they're worried that their PSA is high and they may have prostate cancer, and they want their PSA reduced. In that scenario, the 5-alpha reductase has real value. It puts the patient at ease. It'll shrink his prostate. It'll shrink his PSA. He can be much more relaxed, and he'll see, objective data that the drug is having an effect on his values. But short of that, I think that the 5-alpha reductase inhibitor for most of our patients causes sexual dysfunction, works slowly, doesn't have a huge impact on LUTs, and for that reason, it really is relegated to second or third line management in most of my patients. The one point that was brought up earlier was the potential structural change that a 5-alpha reductase inhibitor promotes and the reduction in retention and need for surgery. And that's real. I believe it. But I also believe it represents probably less than 5% of my whole population. So it really is a very small cohort of the men that I see. And so would I treat 100 men with a drug that may have side effects and a long-term till it actually causes an impact on relief of symptoms for the 5 out of 100 that may benefit from it? That's a discussion you have to have amongst yourselves and with your patients. But in my world, it probably isn't a good ratio of success.
Thank you so much, Dr. Brock. Hyderabad Center, thank you so much. Dr. Gopinath, thank you again. Dr. PVLN Murthy, thank you again. Thank you and good evening to all of you. I'll just stay back in South India, Dr. Brock, for a short while. I have a wonderful question from the Coimbatore Center asking, do we need a cardiology clearance before we look into this combination therapy? Perhaps you would quote the same study which you quoted on the maximum blood rate, presence of both the drugs around, but in your language, is there any cardiology clearance required before we start this in young men or middle-aged men?
No, I don't think it really is necessary at all. And we now have, 25 years of experience with PDE5 inhibitors and cardiovascular risk. We now know that it's actually cardioprotective. We know that it likely has no significant impact on blood pressure, pulse rate, or cardiovascular function for many patients. If anything, it just causes some coronary artery dilation, which is a positive thing. However, if there's a contraindication, then obviously it's not going to be prescribed. In men who have such severe cardiovascular disease underlying that they can't walk, a kilometer in 10 minutes or 15 minutes, or if they can't walk up 2 flights of stairs, then that's a man who you may want to consider not using a PDE5 inhibitor. Short of that, there's really no need for a stress test or a cardiovascular, and certainly not a concern.
Dr. Brock, we are moving India Darshan or Journey of India. We're going to move to the western part of the country and we'll come to the city of Pune. While there's spotlight, I have a question for you, Dr. Brock. Dr. Stephen Kaplan on a personal communication says, I take 5 ARI only once a week. In India, we prescribe 5 ARIs all 7 days a week. Looking into its half-life, what is your prescription dosage of 5 ARIs, the new one, dutasteride, for more than 1.5 decades?
Yes. So great question. The truth is that a lot of my patients on 5 ARIs have side effects, and the side effects they have typically are sexual. So because of the long half-life and because of the studies that were done looking at whether it's finasteride or dutasteride, showing that really the dosing that they're currently using is far in excess of what probably is needed, I very often will go to twice a week. For those men who have achieved the goal that they want in terms of prostate reduction and they're in a stable pattern, it's been a year or 2, their PSAs are stable, their prostate size is stable, their symptoms are no longer an issue, I'll drop it to twice a week. I find that that if I don't do twice a week, it's hard for them to remember to take their pills. When I tried early on in my practice to go every second day, and the guys would simply forget, did I take it yesterday or not? They couldn't remember what every second day was. And then, so they were bothered by that. But if I tell them take it on Monday, Thursday, or take it Tuesday, Friday, then it's simpler for them.
The half-life is 3.5 days. That's what I gather.
Yeah.
If that is what it's so, we are the kings of combination therapy, and we have been giving them combination therapy for years together. I mean, something which again can be a food for thought in the Jugaad or the innovation we do.
Right.
May I come to the Pune Center? Good evening, Pune. Thank you so much for coming in large numbers. Do we have any questions? Sorry for coming late to you according to the rotation that has been given to us. But are there any questions beyond what Dr. Brock has answered? And it will be great to take those simple and complex questions that is coming up from all centers. Pune, the stage is yours.
Hello. Good evening. I'm Dr. Akhil Mane. Sir, what is your experience in young sexually active patients who have more of nocturia symptoms? And second,
nocturia is great question. Nocturia is a very hard symptom to get rid of. And it can be probably the most bothersome, obviously, if it interrupts their sleep pattern. So what I usually do for my patients is I find out, just as was mentioned before, if there's any underlying conditions, what their habits are in terms of fluids, are they having a lot of alcohol or caffeinated beverages. But if really nocturia is their major presenting complaint, I find that very often alpha blockers are fairly ineffective. If they show that they have good residual urine, they're emptying their bladder well with minimal residual urine, and I'm not worried about retention, then I probably would start them on a beta-3 agonist or an antimuscarinic anticholinergic. For many of those guys, especially as you mentioned, a young guy, that'll really solve their problem. For many of the guys, though, it's really that discussion about what are you eating, what are you drinking, when are you having that really may mitigate that nighttime frequency.
Dr. Brock, 15th of March 2024 was the World Sleep Day. Yesterday, which means that we always look at sleeping well and nurturing life, and yesterday's motto was sleep equity for global health. So when you look at that important question, the wonderful question came up. Nocturia happens to be the most bothersome LUTS, which we have not addressed for decades, because Bailey and Love said the first symptom of BPH was nocturia. And then we hooked on to this sentence for decades together before nocturia fell apart and became a full subject. At the Coquelin Hospital, where we look at nocturia bedwetting clinic, we look at this subject where men come and complain only of nocturia. Other things are absolutely stable, as if they are the
yeah.
Team Pune, are there any other questions? Team Pune, we are with you.
So Dr. Pandey, what are you doing for nocturia? What's your answer?
So we look at nocturia for nocturnal polyuria or nocturia minus nocturnal polyuria. So the causes of nocturia is obviously multifactorial and therefore multidisciplinary needs for a multimodal therapy. For those who are on the polydipsia side, estrogen, etc., diabetes insipidus, diabetes mellitus, and the cardiac congestive we still go by because as age increases, the sleep gets lesser and the urine production becomes more. And we are now the masters of urine production. The kidney decides, and we are the slave at the night when the bladder is filled up. The kids are snoring at night while our parents and grandparents are getting up multiple times at night. So the drug called desmopressin, which has now come from the tablet to the melt formulation, has been beneficial. Which age-related caveats? It has been actually non-glorified because of hyponatremia, which can be caused by 50 more drugs in the market, which we are not even privy to. They include the thiazides, the SSRIs, carbamazepines, etc., etc. So I was just trying to shorten this question of World Sleep Day, but I'm still with Pune. Pune, do we have any more questions? That was wonderful.
So what is your choice of drug for young patient who are sexually active and those are not responding to alfuzosin with tadalafil combination?
So sexually active, not responding to the 5 milligrams of tadalafil?
And with combination with alfuzosin.
Okay, so just so I'm clear, that sexually active guy who also has LUTS, and you have him on the fixed dose combination and he's not responding. Okay, you know, just as Dr. Pandey beautifully outlined the cause of nocturia, the cause of erectile dysfunction, and I think you had said that he was a younger man as well. There are so many causes of erectile dysfunction beyond just blood flow. Certainly in the context of a younger man, I would be concerned about situational erectile dysfunction. I'd also like to look at his hormone profile to make sure there aren't reversible causes. His lifestyle, is there some substance abuse? Or more commonly, it'll be relationship issues, situational causes, stress at work that would be the cause. It would be a very, very unusual young man who has a vascular cause of his erectile dysfunction or a neurogenic cause of his erectile dysfunction not to be a responder to 5 milligrams of tadalafil. Dose, and he isn't responding, would lead me to be suspicious of non-physiologic conditions. So I would really explore the non-organic causes in his situation, which I think would be the likely source of the failure.
So, thank you, sir. But I want to ask in other way around, the patients sexually active, but urinary symptoms are not responding, or not about the sexual function.
So his urinary symptoms are not responding. I'd be worried about, does this man have a stricture? Is there some other cause that's perhaps inducing his problem? I would look at things like, is still having prepared cystoscopy to rule out any other structural issues. You may want to then look at either beta-3 agonists or antimuscarinic anticholinergic agents. But I would do an investigation for him, because I think we all recognize, if we're talking about a truly young man, not responding to an alpha blocker with LUTs, again, would be pretty unusual. So we have to look at our differential diagnosis. Did we miss something? Is it a problem with high sugars, a urethral stricture? Is there some other bladder sphincter dyssynergia that we didn't notice because of some neurological problem like MS, recurring and remitting? So those would be the approach that I would use.
Thank you, sir.
Thank you, Team Pune. Thank you so much. Allow me to move on, and we will move from Pune to Thane, the city of Thane in Western India. Is Team Thane live? Can we spotlight? Good evening, Thane. Can we have your questions, please? Dr. Brock, you would agree these are all most challenging questions as the subject has been opened up.
Great.
A to Z. We'll
That's
take
wonderful.
Team Thane. Team Thane, are we left with any questions with the way we have been rotating around? You have been enjoying this. Are there any questions that Thane would like to ask?
Should we address the chat questions? What do you think?
We have got the live centers around, so we're just looking at Team Thane at this point in time.
Yeah.
Has the team not did spotlight on Team Thane? Okay, we will stay with Trivandrum right now. Dr. Brock, we go to South India and we have, yes, go ahead, Team Trivandrum.
Good evening, Dr. Brock and Dr. Sanjay Pandit. This is from Trivandrum. I'm Dr. Vinod KV. I have two questions for you. One is a clinical situation, just like we discussed. A young male coming with LUTs, mild LUTs and ED. Would you contemplate on starting him straight away on the FDC or the combination of alfuzosin plus tadalafil, or you try as tadalafil first and then alfuzosin, then the combination? Because the worry is, are we over-treating the patient? My second question is on the molecular mechanism. As we know, the PDE5 inhibitors are working well in managing the LUTs. But that effect is not replicated in if you are trying with sildenafil or abnafil, as you have rightly pointed out. So what is the exact reason for this? Is it because the tadalafil is having some other mechanism which is working? Or is it because of some of the isoenzymes which the tadalafil is selectively blocking in contrast to the other PDE5 inhibitors like sildenafil?
So,
thank you.
Yeah, so very insightful question. While there are some differences among the major PDE5 inhibitors in terms of their relative selectivity to the other PDE isoenzymes, by and large, there really aren't any significant physiologic activity from PDE4, PDE3 that really these drugs work on. Really, it is PDE5 and for the others, PDE6, which is 1/10 as selective for the other PDE5 inhibitors apart from tadalafil. And so the real rationale, the real understanding of why tadalafil is an effective treatment for LUTs, whereas sildenafil, vardenafil, avanafil are not, has to do with half-life. There were studies that looked at sildenafil when it was taken 2 or 3 times a day, and then it became quite effective for lower urinary tract symptoms as well. But it wouldn't work because who wants to take a drug 3 times a day? It would be the cost, the inconvenience, and so on. Plus, the other thing is with tadalafil, you can use a smaller dose, and because you take it every day, the concentration in the systemic circulation accumulates. And so you get the advantage of a low dose you're taking with low side effects, but a pretty good physiologic effect because it does accumulate. The question about what I would do for a young man It really comes down to your approach and your philosophy. I think that if we didn't tell you that this new combination drug actually had two different drugs in it, and it was just some sort of purple pill that Cipla put out, and that it was available, and they showed you the data, I think most of us would say, well, this is a drug that works both with erection function and lower urinary tract symptoms, and that's what this guy has, and it's better than either one alone. Why would I not want to use it? The only reason not to use it would be if the side effects were worse, and we've shown you some data that really they're not, or if the safety was a concern, and that clearly isn't the case, or ultimately if the cost was very much more prohibitively expensive, but my understanding is that that's not the case either. So the short answer is, yes, I would start the combination pill as my first line because it's faster, better, safety is similar, and I think you'll find the patients will have more of a result. If erectile dysfunction and lower urinary tract symptoms, and that's what you're addressing.
Thank you, Dr. Vinod. Thank you. They are the best of questions coming up around. My apologies on attempting to moderate the most one. Thane, if not Team Thane, can we move to Team Cochin? Are there any questions? We've got wonderful questions online from others. We've answered Team Coimbatore already. And unmute Jaipur as a center. So we could look at Jaipur. If there are any questions, Team Jaipur? Can you unmute if Jaipur is ready? Yes, please go ahead. Can you unmute Jaipur, please? Sorry, sir. Sorry, you're not audible. Sorry. Team has to unmute you, Jaipur. Yes, go ahead, Jaipur. Sir, please ask your question again. Please go ahead.
So I'm sure you and Dr. Gerald must be excited, but there is a difference between you two, sir. I can see a glass of crystal water.
My ski is waiting outside. I'm in a hospital setup. Dr. Gerald is actually post-noon. So post-noon can be darkness at noon.
Thank you, sir. And you have answered them beautifully. My question is regarding the surgical aspect of the management clinic. By my professor, sir, that a young male who has got a median lobe response very poorly would be the surgical indications of management of bloods who are paid medical therapy. When would you advise surgery in bloods in young males?
Thank you for the question. You're absolutely correct that it is a significant issue in a percentage of men when the median lobe is causing a ball valve type of obstruction. And that typically is not. We used to think many years ago that would be amenable to 5-alpha reductase inhibitors. But the truth is, if there's a significant median lobe, even if you do shrink it to some extent, it typically doesn't relieve the symptom complex in many of these men. The good news is it would be a pretty unusual usual scenario, particularly in a young man. Most young man, old man cutoff is a fluid idea. And so, young to you may be old to me or vice versa. Having said that, a failure to me would be if that man is still not symptomatically improved. I would then want to look at other things that could be causing his problem, that he's not responding to my medical management. And that would include doing a cystoscopy, doing a urodynamics study, and really assessing the anatomy and physiology so that I could better understand why he is still symptomatic, particularly in a young man. What we do in Canada for those who have, whether they have middle lobes, if they have large prostates, small prostates, if they are unresponsive or unwilling to take medical management, the first line therapy in our clinic is we do ahead and do a resume. I'm not sure how prevalent that is in India. We also do green light lasers. We do holmium lasers. We do standard bipolar and monopolar TURPs. And that would be sort of the options that we provide. Although in the city next to us, Toronto, they're starting to do Eurolifts. We haven't started doing those in London yet. I feel a little uncomfortable leaving a permanent prosthesis, a permanent device in the urinary system if we don't need to. So those would be the approaches that we would use here in London.
Thank you, Team Jaipur. I've been told that it's a weekend evening, and I would look at the last final questions which have come on the chat box. Very, very interesting. Please stand by for the last few questions before we give a standing ovation to the champion of the day. Coimbatore said, how long to use? You've already answered. It could be lifelong or it could be long-term therapy. We escalate and de-escalate depending on the kind of requirements. The size of prostate has got no meaning, Coimbatore. We will look at any sizes. We look at the symptomatology in this kind of a condition. Dr. Neeraj did talk about directly moving from treatment to a cure, and that's where you answer those questions. I'll just move on to few questions before we come to a close. Number one is Center Bhubaneswar. Dr. Sameer, thank you for this question. Is it required to exclude hypogonadism in cases of BEP and sexual problem before starting alfuzosin and tadalafil? Your one-liner for this.
Well, I do testosterone in all my patients. I think it really is important because it's been shown that hypogonadal men have an increase of cardiovascular bad outcomes. And certainly it is a reversible cause of erectile dysfunction. So uncovering low testosterone is something we do as a routine.
Perfect. From Indore, would you give this combination to young males with LUTs and do not complain of sexual dysfunction?
I would have a discussion with them, and I think that most men would probably be open to the idea of improving their erectile and sexual function if that was a safe and an option available to them. On the other hand, if there is clearly no erectile dysfunction, no concern, certainly trying an alpha blocker to start with would be very reasonable, but the data would say the combination therapy probably is more effective and would work more quickly than monotherapy. So that's a discussion you'd have with the patient.
Terrific. Dr. Amitabh from Patna. So this question is important. A patient on fixed drug combination got better with fixed drug combination, saluted you and me, worsened when off the fixed drug combination. Came back now complaining of erectile dysfunction. Given tadalafil 5 milligrams, came back staying still ED not as good as was the fixed drug combination. Can you explain the rationale behind the phenomena of the...
Actually, there are some studies now, they're quite old, they're probably close to 20 years old, that showed the combination of an alpha blocker and a PDE5 inhibitor were synergistic. And the rationale behind that was that, when you're causing, when you're taking an alpha blocker, you're causing vasoconstriction. And in fact, and synergistically from the PDE5 inhibitor. So the rationale for the studies that were done, again, almost 2 decades ago, show that there may be some synergistic activity. And I think that's what your patients experience.
Considering the effect of tadalafil as an anti-inflammatory agent, you would consider an fixed drug combination with tadalafil in patients with BPE and prostatitis? So you have been a master.
Yeah, so the data on that is really not great, but you're right. One of the hypotheses in terms of the mechanism of action is an anti-inflammatory effect, and certainly that's also the case with testosterone. So while people always for years were worried about testosterone causing exacerbation of lower urinary tract symptoms in BPH, the data on the hypogonadal population is that very often they get better on testosterone, and that is thought to be through anti-inflammatory mechanisms.
Thank you. There's one question from Indore. I would take patients on 100 milligram sildenafil for ED develops LUTS. Will fixed dose alfuzosin, tadalafil take care of both of his problems?
Yes, almost certainly.
Great. Paul Vincent talks about how do you say a 45-year-old man with LUTS with slight low Qmax is having LUTS due to BPH? I may think about bladder neck dysfunction rather than LUTS due to BPH.
Yeah, it varies. I think that, how are you going to treat his bladder neck dysfunction, and why does he have bladder neck dysfunction? Does he have some underlying neurological condition? Does he have something else going on? So I think these patients, if they're a little bit unusual, can deserve an appropriate, more involved workup. But for the general man who's 45, the likelihood is his LUTS are related to prostatic obstruction.
So somebody from Cochin, Dr. John Abraham, our colleague, did ask, can we start it as a first choice FDC combination in a young patient instead of monotherapy with alfuzosin, knowing that he could be having some degree of ED too?
Absolutely.
Perfect. I'm coming to the last few questions. There has been so much of applause and so much of respect for what you have actually done to us. I think this looks like a wonderful session that we have had. Friends, allow me one or two questions which could close this completely. Tachyphylaxis, no tachyphylaxis is what it is. In one of my patients on alfuzosin, Dr. Amitabh from Patna, plus tadalafil, once his LUTS improved, he was off the drug and then he complained of ED and was advised tadalafil. I think I came to this question. It has been posted a second time. My apologies on that. I am coming to the last of it from the Maximum City. We have a question from Mumbai. I can't see it. Apologies. I'm not able to see any more questions which are new. There will be questions which are messed up. But friends, you would believe, before we come to a close and before we give a real standing applause to the champion of the evening for us, and one who started at 4 noon and ended in the afternoon, they say Elvis Presley never wanted to be a singer. He wanted to transform music. To the incumbent ISSN president 2020-2024, I would say there is a mini Elvis Presley within him. On one side, he would take the LUTS, other side, he would take the erectile dysfunction. Sir, you have been a champion of men's health today, and we all need to have mini Elvis Presley within us, which we are. As you've seen, India questioned you. Thank you so much for responding. It is something where magic you make every day as a urologist, between the thighs with a telescope or between the thighs with a digital rectal examination. It's time to take this subject head on. My sincere salute to you for having been there for 2 hours and 11 minutes, non-stop, just sipping one single glass. Thank you so much. A standing applause to all, to you from all of us in India. India salutes you and looks at this as a shining combination of therapy which many men required. They will not be relegated to a monotherapy of either of them when they require so, because a lot of juniors were in the audience and they could not have asked questions. But all the questions you actually did answer in your 25-minute presentation. And then came up this large presentation of question which came actually is unprecedented. The subject has been there rolling around cities in the last 1 year, but the amount of questions which came up today has come directly from the practical aspects urology colleagues face, which our teachers has asked, our colleagues has asked. So last word from you, Dr. Gerald Brock, before we let you sip more. It must be a dry throat. Thank you, colleagues, for joining in from all over the country. There were a few thousand of them who heard you, Dr. Brock. You are going to come back to the city of Chennai to the next conference after we met in Patna. Thank you for you having come here. And thank you for the large numbers. Sipla, thank you for doing this multi-city summit on men's flow. And the flow will continue to happen in the turbojet that we're creating for the semen, for the urine, and for everything that we have talked about. Dr. Brock, your last few comments.
Dr. Pandey, Dr. Nabar, gentlemen, audience, all the participants, it was a wonderful experience. fantastic questions, and what a fantastic moderator. So I think that you handled this very complicated evening with great aplomb and style, and I would be willing to work with you anytime in the future. Thank you, everybody.
Thank you, Akshay. You can take the stage and probably thank everybody.
Thank you so much, sir. Thank you, Dr. Brock, for your wonderful insights and for bringing in the translation right from the bench to the bedside and everything that goes in between the nuances which urologists all across India have been facing and have been voicing to you very enthusiastically. The enthusiasm of you and Dr. Pandey in particular has been very impressive. And I'm sure that this is truly going to be the Flow Summit, which will turbocharge and rejuvenate all of us and everyone's knowledge and interest in this topic, which has kind of been a needy yet not reached population thus far. So thank you so much for bringing in the clinical insights. Thank you so much for the theoretical rigor and for enthusiastically and meticulously addressing all the audience queries from not only pertaining to the topic, but even beyond, and giving a very holistic view, which I'm sure will benefit all of us out here in India and give us a lot of food for thought and directions in the future for various actions. So I thank the audience also for their very enthusiastic participation and coming in with a lot of doubts and questions, which will lead to further questions and more answers. And these answers, we hope, will ultimately benefit the patients, which is the common objective of all of us. So thank you all for joining us this evening. Wish you all a very happy weekend and days and months ahead. Thank you and have a very nice evening.
Our apologies for whose questions we could not answer, but overall, the champion of the evening had answered everything around. We go back very happy and probably educated. We have gone back without those dilemmas. Thank you, Dr. Brock. My apologies for holding you back longer than we had thought about, but great. I think it's probably a deep immersion which you've taken in. Akshay, thank you so much. Cipla, wonderfully done as a summit for multi-cities around, and thank you all the cities who've been around. It's time for dinner in India, Dr. Brock. We'll catch up again in Chennai and in other meetings around when we meet at the ISSM.
Thank you. Thank you.
Thank you, sir. We are offline.
Thank you, sir. Wonderful.
Thank you.
Superb. It was very participative. It was very participative, very well moderated by you. Lot of interesting cases, lot of interesting case vignettes, and the basic aspect jo aaya na sir, tachyphylaxis, half-life, ye basic cheezein, these got the message got across through your discussion.
Absolutely.
So thank you for bringing across these points, which brought about this discussion, because we are really oblivious to so many things which obviously are there.
We got in a lot of spontaneous questions which have been asked. Why Tadalafil and why not Sildenafil? Why you don't want 2.5 and why India loves 2.5 to start and then go to 5, because it's a confidence building as much for a urologist as much for an individual on the opposite side whose safety we're looking at. So I get a lot of questions. 24.5 years in urology, 8 days a week. I've been doing this. I enjoy this because we could bind everybody together, and it was great fun. Colleagues, seniors, teachers all asked questions. They opened their heart out to a champion who actually was. Please pass our salute and a big respect to him, the way he actually came in around, because to be there for 2.5 hours is just not easy. It will probably, I'm used to it, but not many are used to it, where you continue speaking non-stop and take it and balance it all the time so that none of us miss it out. So
yes, sir. Thank you, sir. You stimulated it. He brought about